From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to this JAMA Author Interview podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm speaking today with Dr. Eduardo Bruera, the F.T. McGraw Chair in the Treatment of Cancer and the Chair of the Department of Palliative, Rehabilitation, and Integrative Medicine at MD Anderson Cancer Center in Houston, Texas. Dr. Bruera is the author of an editorial published in JAMA titled Improving Palliative Care Access for Patients with Lung Cancer. In this editorial, Dr. Bruera highlights the findings of two trials published in JAMA that test interventions to make palliative care more accessible. In the trial published today, Greer and colleagues randomized more than 1,200 patients with lung cancer to have their follow-up palliative care visit delivered either in person or by video, and find equivalent quality of life improvements in patients regardless of the mode of delivering this care. Dr. Bruera, thank you for joining me here today.
Thank you so much for having me.
So I really appreciated the editorial that accompanies this paper and a previous paper that also looked at an intervention to expand access to palliative care. And what I love is that you really do set the context. And I learned immediately testing whether patients need palliative care is not a new idea. This has been around for a while. So give us just a little bit of a sense of how long we've been thinking about palliative care and really understanding that it's important for patients.
Absolutely. The first concept of palliative care emerged in the 60s. It was, certainly older than most specialties we have right now in medicine, including medical oncology, critical care, emergency medicine, but it grew out of the suburbs. It did not grow from academic medicine. And so it took a long time for academic medicine and acute care medicine to adopt it. And it started the adoption in the 90s and the 2000s, and probably around 2010, we started seeing major randomized controlled trials demonstrating the great advantage of having palliative care as part of the care of patients, mostly with cancer. There have been other studies that are starting to show similar results for heart failure and COPD and so on, but overwhelmingly the evidence is related to cancer. And so the evidence is now overwhelming that patients who access palliative care before the end of their life have better quality of life, have less aggressive unnecessary treatments like ICU, dialysis, intubation, etc. And it even reduces dramatically the cost of care. So that evidence is present. Regrettably, we have a little bit of a crisis of adoption at this point.
I see. So the evidence really is overwhelming in cancer care that this is part of the care that we hope to provide to improve a patient's quality of life, improve outcomes, and the evidence is overwhelming, and we've known that for a while. But as you point out, the adoption or the adoption at scale, really, so that all cancer patients have access, has been more limited. That is the context for the new studies that we talk about, which are figuring out ways to improve access. And maybe you can just put that in context. Where is the literature right now?
The problem with palliative care is that it's complex care. It's not easy. And therefore, it's not something that I can teach a physician in one day or give them a brochure and have them, hey, do primary so-called palliative care to your patient with cancer, CHF, and so on. It requires some level of expertise. And as every area in the history of medicine, when the body of knowledge is limited, you have to be more of an expert. When the body becomes very well known, when we understand perfectly well what is in the palliative care syringe, then it becomes easier to generalize. At this point of development, the specialist care is what is lacking and what patients don't have always access to. And so these two studies provide powerful ways of increasing the access for patients who normally wouldn't, the ones who have difficulty making it to a hospital or who live far away on one hand. And the other paper looks at, could we reduce the number of encounters with a palliative care specialist and maintain the quality of life of the patient? Both studies have positive findings, and they are encouraging to all of us practicing in this field that this will further increase patient access.
I found it really interesting that you point out there can be a preference for having video palliative care encounters.
In the case of very advanced disease, there are major barriers to coming to see the doctor. Those include their physical symptoms, their profound fatigue, the pain, the dyspnea, the nausea. These include also emotional barriers. They're depressed, they don't want to dress up, they don't want to leave their home. It also puts a lot of pressure on their families because many of these patients don't drive and they have to be, a family member has to take half a day off to take them to the doctor and come back. And so there are major barriers related to the physical and psychosocial situation of the patients when they have advanced disease, particularly advanced cancer. There are also issues of the frequency in which I'm going to be able to make those encounters. Driving 45 minutes, paying $15 parking, and then waiting 2 hours, and then seeing my doctor, all that adds time toxicity to people who are very ill. And so staying at home and visiting with my doctor becomes very appealing for patients in that stage of their lives. And we've done some surveys, anonymous surveys, and patients overwhelmingly support getting access to video care as an alternative to come to the hospital.
So the findings of improved quality of life in both arms is actually good because then ideally, as you suggest, this is really specialized care now that will hopefully improve access because more of it can be delivered and it might actually be something that patients prefer.
Absolutely, and that's a wonderful way to put it. There will always be need for hybrid care. That means we cannot provide universal video care. Some patients have sensorial deficits, some patients have cognitive deficits, some people have no clear access to Wi-Fi and services, some people need to be physically examined, and some people need urinary drug testing and other things that need to be done in the in-person setting. So it will never be a kind of a universal resolution, but what we learned is that you can deliver a large majority of your care virtually and then always have the ability to switch that rapidly to in-person.
Wonderful. So why? So you've described now a field that's existed since the 60s, at least probably 1 to 2 decades of high quality studies showing overwhelmingly. Why don't we adopt this more?
That's a wonderful question, and I think a lot has to do with culture. The culture of medicine, the culture of high-tech medicine, the culture of cure. I described many years ago that there are 4 stages in the development of a palliative care culture. The first is denial. We don't have that problem. We send people to hospice and they have no issues. And it can be really addressed by asking 100 patients in your hospital if they're doing okay, and it will become quite clear that they're not doing okay. The second one is palliphobia. You are very fearful of establishing palliative care because it might be construed as euthanasia, patient neglect, inappropriate care, and so on. And that can also be easily addressed by having 2 or 3 friendly doctors send you patients, seeing them, and then presenting the data to the rest of the colleagues and say, you see, none of that happened. The patients did better, and the referring doctors went home earlier. The third is pallilalia. That is nonsense talking about how good palliative care is, but not doing anything about it. That's the most dangerous stage because the few palliative care specialists get flooded with referrals, but they don't get the resources to address that. And that requires measurement of how am I doing as compared to the cardiologist, internist, or oncologist in my institution to get similar resources. And the final and the graduation is palliative, in which you have the administrative structures and the resources that allow you to have a practice that is serving the patients and serving the referring doctors who are so grateful when they're able to get care for that patient.
So where are we now? We're sort of moving in that acceptance of palliative care as a part of high quality care for patients, but not quite having the resources to do that. Would you say that's where we are mostly?
Regrettably, you're absolutely right. We are mostly in the palliative stage in which institutions talk about it, but don't necessarily make the investments and the creation of the structures that will serve those patients. And it's a paradox because the power is in the hands of the executives, and the executives love metrics and love money, and we can give them both. So I'm optimistic that they will do some reading, they will read JAMA this week, and then they'll go to work and make those programs happen.
Well, it's been such a pleasure talking with you about this very important topic. And thank you for writing for our listeners. I'd urge you to read both the two trials as well as the editorial that Eduardo has written. And the editorial at the end has many other areas that should still be addressed if we're going to really scale these types of interventions. But hopefully we're moving towards a more active uptake. Dr. Bruera, thank you so much for joining me here today. I really enjoyed this conversation. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. I've been speaking with Dr. Eduardo Bruera about his editorial on improving palliative care access for patients with lung cancer. You can find a link to the articles described in this podcast in the episode description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.